Hi everyone, and I want to thank Dr. Wong again for his kind invitation for me to speak today. Today I'll be talking about the nasal cavity, its anatomy, its function and its physiology. And unfortunately on your programs that you probably can see, I've been allocated about half an hour for this talk. So if I were you, I'd have your phones ready and charged because it might be a little bit dry. But jokes aside, this is something that I'm very passionate about. Nasal obstruction and the aspects of the nose that we can fix and really create a functional difference for our patients. So I'm very excited to be here to discuss this all with you today. All right, hopefully that's a bit better for you guys. So I have no disclosures to declare. Before I start, I think Dr. Singh has already gone through, but I wanted to talk quickly about SCONA. We started this society as a collaboration between surgeons who are receptive to CFD as a potential technology that will really change our practice and our understanding of the nose and airways and answer some of the questions that we've always wanted to answer and revolutionize the way we practice rhinology. With engineers who are willing to put up with the difficult people that are surgeons. And so this is just a bit of a cartoon that shows us what can be achieved with collaboration. And this is the sort of visual representation for what we want to achieve with SCONA, because I'm probably as surgeons, we're probably the guys sitting at the back. We've got no idea about the engineering side of things. And we were pretty successful with our first step at the World Congress in London in April that Dr. Singh spoke to you about. So thanks to everyone who came to that event, and thank you for everyone who made that event possible. Understanding sinonasal anatomy is often very challenging, particularly for those who aren't in the medical field. And even for us as trainees, we find it very difficult. And there's a number of reasons. Firstly, we make it difficult. That surgical textbooks often do not help delineate what is clinically relevant and what is not. And as a result, there's a lot of minutiae that is described in detail, but that's at an expense of just good basic understanding. The sinonasal cavities, particularly in the context of surgery, is learnt really by understanding the three-dimensional structures of the nose and their relationships to each other. And this, is really when I started first understanding anatomy, and really is when I had my own endoscope. I started to do some basic operations, started to look in noses myself, and that really facilitated my personal learning. And finally, there is significant variability between sinonasal cavities of different patients. This is due to a wide breadth of normal variants, as well as pathological variants and prior surgeries. So because of this, I just want to talk about the anatomy and physiology that I think is clinically relevant, at least at a basic level, and at least to the level that we have as we understand as surgeons. And maybe I'll discuss a few things that are perhaps less understood and CFD may bridge the gap to later on. So firstly, I want to separate the nasal cavity from the paranasal sinuses. So this is an axial CT scan of a patient's nose and sinuses, just in one slice. And on the top right, I've outlined the nasal cavity, and on the bottom there's some of the various paranasal sinuses that I've outlined. And for the purposes of this talk, we will be discussing the nasal cavity only. Just briefly, the four paranasal sinuses, there's the maxillary, frontal, sphenoid, and ethmoid sinuses. They're hollow cavities that are situated around the nasal cavity, and really there's no specific known function. There's a lot of proposed functions out there: reduction of the weight of skull, improvement of vocal resonance, improving the heating and humidification of air, and a source of mucus production. And each sinus drains into the nasal cavity through a number of different duct systems. And while there certainly are interactions between the paranasal sinuses and the nasal cavity, particularly in disease, in the normal sinonasal cavity, only 1% of nasal airflow goes into the sinuses, and that's the reason why I'll just talk about the nasal cavity in this particular talk. So for simplicity, I'll separate the nose into the external and the internal components. The external nose has two components, which I'll go into, and the nasal cavity, I'll separate them into the nasal septum, which is in the midline, and the lateral nasal wall, which sits on the outside. So the external nose, there's a bony upper third which comprises of a number of bones, but predominantly the two nasal bones and the immediate articulations, or the interfacing the maxillary and frontal bones. And in the lower two-thirds, there's it's cartilaginous, comprised of the upper and lower lateral cartilages. So going into the nasal septum, which is in the inside, this is also complex, comprising of both bone and cartilage. And the function of the nasal septum is to separate the left and right nasal airways. So in addition to the septal cartilage that's coloured at the front, the septum consists of the vomer, the maxillary and palatine crests, and the perpendicular plate of the ethmoid bone. Within the complex, amalgamation of structures that make up the nasal septum, deviations to one side or the other are actually very common. Up to 80% of patients have some sort of deviation to one side. In this CT scan that I've shown, clearly there is a deviation just towards there. It says to the left there, which may cause nasal obstruction to that patient, or it may not. A number of causes of septal deviation can occur. Many are congenital and have been developed since birth or early childhood, but many can also be acquired after trauma or other causes. So the lateral nasal wall, so moving on to the side, comprises of the pterygoid process of the sphenoid, the maxillary bone, and the inferior nasal concha bone, as well as the ethmoid bone. And the important part from the lateral nasal wall that we need to keep in mind is that there are three turbinates or concha. ENT surgeons, we call them turbinates, but you might find them named as concha in other textbooks. But they're bony projections from the lateral wall into the nasal cavity, and we call them the superior, middle, and inferior turbinates. They have a bony compartment or component and an area of soft tissue around it that then is lined with the mucosa or the skin inside the nose. And the soft tissue is made up of a large network of venous sinusoids. It's quite vascular tissue. And there are also receptors on the mucosa. There's thermal receptors, there are airflow receptors, and they respond to allergens, temperature, and humidity. They function in filtration of particles and humidification of nasal airflow. And some patients have hypertrophy turbinates or enlarged turbinates. Perhaps it's secondary to excessive exposure to allergens, or it just maybe their natural or normal anatomy. And we often reduce the turbinates if patients have nasal obstruction, and we believe that may be secondary to the turbinates, and there's a number of ways that we can do that. There is also a belief within most, generally accepted, that there is a nasal cycle, that one side of the turbinate swells up and is congested while the other is relatively uncongested, and this swaps periodically every 3 or 4 hours or so. The additional role of the nose is in smell. The olfactory bulb of the first cranial nerve sits above the cribriform plate of the ethmoid, and it passes a few fibres into various parts of the upper portion of the nose, or the superior portion of the nose. We call that area the olfactory neuroepithelium, and this lies on the upper part of the nose, but more specifically the superior nasal septum, the superior turbinate, the cribriform plate, and the superolateral nasal wall. So now I'm just going to move ahead to some of the things that perhaps are less well established and areas of potential research. I think first that I want to talk about is the nasal hairs, which Dr. Kiao Inthavong is working on at the moment. And so as far as our understanding of nasal hairs is that it's a first-line defense against larger foreign particles from entering the nose. It may contribute to increasing humidity of inspired air. And I don't want to step too much on Dr. Inthavong's topic, because he may talk about this later. But in my mind, I can't imagine that the thick circumferential hair on the left doesn't have at least some impact on nasal breathing or nasal obstruction when you compare it to, say, the video on the bottom or on the right where there's much less hair. And certainly patients anecdotally, when we trim the hair as part of their surgery, seem to report improved breathing and perhaps some reduced discomfort as well post-operatively. Another component is the septal swell body. This is a portion of a normal anatomical structure that we see that sits high up in the nasal septum, and it's been shown in previous studies to have histological, or the cells are very similar to turbinate tissue with venous sinusoids. But it's something that's not well established, and most surgeons don't address this during operations for nasal obstruction. So perhaps research into the behaviour of the swell body in nasal pathology will help us determine if addressing this structure in surgery might be worthwhile, and perhaps CFD can give us that answer as well. Thank you.